Hello and welcome back. All right, we're going to continue with cell injury, now focusing on the irreversible, okay, meaning it can't go back. We've got necrosis and apoptosis as our two types. For this particular video, I'm going to focus first on necrosis. Apoptosis, I'll have another video because I want to go over a little bit of the pathway associated with that, okay? This tends to be messy cell death, apoptosis tends to be clean cell death. And with this one, it's not always pathogenic. Necrosis is always an abnormal pathology, okay? So that's just some of the quick differences, all right? We'll go ahead and focus on necrosis for now. So with necrosis and the irreversible cell injury, all right, typically your etiology is going to be something like ischemia, a lack of blood flow. You can also have high calcium levels that's going to activate those enzymes, okay? In this case, some examples of some of those enzymes, things like ATPases, phospholipases, and endonucleases. So you're interfering with ATP, you're interfering with the cell membrane, you're interfering with other cell processes, maybe it's taking apart the RNA or the DNA, okay? These tend to be catastrophic, the cell can't recover. All right, and typically, this is going to lead to cell rupture. So the cell membrane will eventually give way. And because of that cell rupture, you are also going to have an inflammatory response. So you're going to have immune cells like macrophages coming in. And that's going to be one of the key differences between necrosis and apoptosis. Necrosis will always have an inflammatory response with it. Apoptosis does not induce an inflammatory response. Okay? So with necrosis, what you're going to do, or what you're going to have happen, you've got digestion or breakdown of cells, and ultimately that is also going to lead to tissue damage, okay? So if you're interfering with ATP, if you've got an increase in calcium and you're breaking down cell membranes, you're breaking down DNA, the cell can't recover from that, okay? So with necrosis, we've got a couple different types. All right, the first one is going to be coagulative. This is one of the more common types of necrosis. And the etiology with that is going to be typically ischemia. Okay? And that ischemia ultimately leads to a loss of the plasma membrane. All right? That causes the cell rupture, and what you end up getting, the cell ends up being degraded. All right? Common place where you can see this, myocardial infarction. Always fun to say. You don't ever want to have one if you can avoid it. Okay? Or more commonly, a heart attack. Right? The coronary artery that supplies blood to the heart gets blocked. You get an area of the heart that doesn't receive oxygen. That causes tissue damage. That causes an area of tissue to die. And that's an example of where you've got coagulative necrosis. Okay? Liquefatic. All right? So in this case, the dead cells end up dissolving or liquefy. Okay? Typically, what we're talking about here, you've got enzymes that are breaking things down when they shouldn't. Can be also due to ischemia. For example, in the brain, right? You get blood flow, lack of blood flow to the brain with a stroke. And essentially, those cells kind of turn to a pile of goo due to the lack of blood flow. All right? So, liquefatic, we've got fat necrosis. Now, this one tends to be a bit more tissue specific, so you're talking about either fat tissue or the pancreas is another place where this can happen. Essentially what you've got some fatty deposits that form, and you've got that particular tissue then dying, and it tends to look kind of like soap when you look at it histologically. So essentially what ends up happening, it looks kind of, I don't think there's a U in there. It looks kind of soapy or chalky. Excuse my erasing. As far as histologically. And really, when we're talking about the different types of tissue necrosis, the histology is going to be what is used to distinguish whether it's coagulative, liquefatic, or a fatty type of necrosis. Okay? We've got caseous necrosis. All right? This one tends to be due to infection. All right? Essentially what ends up happening, the tissue kind of walls off the area of infection. So a great example of this is tuberculosis in the lung. People who have long-standing tuberculosis infection, what'll end up happening, the lung kind of partitions off that area where the bacteria is to prevent the bacteria from spreading to other parts of the lung. But as part of that, you've got necrotic tissue. The lung tissue that was there is no longer present, no longer functional. You aren't getting air exchange there, okay? That caseous necrosis, that would show up as lesions on the lung in an x-ray, all right? And then my favorite, you've got gangrene as a type of necrosis, okay? And with gangrene, you can either have dry or wet, okay? Or gas, all right? The gaseous gangrene is kind of a subdivision of wet, all right? Essentially what you've got with gangrene, it's a type of coagulative necrosis. So I leave this towards the end, but really these two are a little bit related. This is why that coagulative necrosis tends to fall into the most common category, because gangrene is a type of coagulative necrosis, okay? So in this case, you've got large areas where you've had ischemia, you've had a loss of blood flow, and maybe I should put a little more space here. Hold on, let me get my better eraser so that I make it a little bit less messy. All right. So you've got a large area of coagulative, oops, that's an O, necrosis. You've got a clear line between what is normal tissue and what is dead tissue, okay? Frostbite can lead to dry gangrene, as one example. It tends to be relatively slow in its spread, but the tissue is going to look different. It's going to look brown or black. Definitely not nice and normal pink, okay, with the skin. Our moist gangrene does not have a clear line of demarcation associated with it, okay? The moist gangrene can either be coagulative or liquefatic, okay? But it's differentiated between dry because you don't have the clear line of demarcation. The moist gangrene also tends to have a foul odor associated with it. And often you can also, if you've got a foul odor, it's associated with infection, okay? So we've got dry, moist, gas gangrene is essentially a type of moist, but you've got a very specific bacteria. You've got Clostridium perfringens. So perfringe. Okay. This has to be treated aggressively because what ends up happening, the Clostridium perfringens produces a gas that causes a bubbling. Of the skin, okay? None of the gangrenes are good. You want to avoid them if you can. This one's probably the worst of them, okay? Because what it ends up producing as far as gas is hydrogen sulfide gas, okay? And that hydrogen sulfide gas produces, also is going to be toxic within the body. Clostridium perfringens itself also produces toxins that can cause damage or cell death, okay? This one spreads very fast. Whereas dry gangrene tends to be fairly slow, wet gangrene, not super fast, not super slow. The gas gangrene spreads fast. That's why it has to be managed more aggressively, okay? So when we're talking about necrosis, all right, the damage is too severe to undergo those adaptations, all right? That's why this is a terminal pathway. So those tissues, once you're talking about having gangrene, typically those tissues need to be removed surgically to prevent death, okay? Also tends to be painful for the patient. You're going to have inflammation. Along with inflammation, you're going to have fever associated with it, okay? Ultimately, you're talking about losing function in whatever tissue happens to be affected, all right? Hopefully that all makes sense. If you have any questions, please let me know, and thank you for your time.